193, calf raises on leg press, single or bilateral. Person grabs this, goes up. Don't grab anything actually, so disregard that. So basically calf raises, if we're gonna do this bilaterally, you wanna have that 4 foot on the platform, not so high like this where there's really no room to drop, not so low that they're just basically on their toes, so you wanna be up a little bit. So heels drop a little bit, go all the way up, drop, go all the way up. If you want to do this single, 1 foot would be down, and again, down, all the way up. This is on the lightest weight, but you can have the person basically show you how much range they have, and they need to get the same range with whatever weight you give them. If they can't get all the way up with this weight, since it's the lightest weight, therefore they're not ready for this exercise, they have to go back and use the plantar flexion with the T-band. So, but if they are, come down, knees slightly bent, go all the way up, down, all the way up. Pretty self-explanatory. So this is going to be called the soleus raise, okay? Foot's on here, go straight up, straight down. Again, this exercise is called the soleus raise. Okay, number 194, seated single calf raise with a dumbbell. If we had a towel, I'd be putting a towel over here. I don't really need one, but the person's foot, same thing, goes on here to allow the heel to drop. Since we are bending the knee, we're taking the gastroc out of it, so now there's a straight soleus exercise, which if you wanted to cut away the gastroc and peel it back, there's a muscle called the soleus that's right underneath, which we explained before, joins in with the gastroc to form the Achilles tendon to allow for plantar flexion. So when we bend the knee, we put it over here, and we would allow the heel to drop, put a weight right over it. The person just basically holds it here, and they allow the heel to drop, and they go straight up. This weight doesn't matter. You don't include this. This is just a dumbbell you want to put down. A bigger foot, grab a bigger dumbbell. You don't need to grab like a 70-pound dumbbell. This is a 40-pounder. This is the weight that matters. So this is a 30-pounder. You would just write single, whatever, calf raise on dumbbell, 30. They go all the way up, come all the way down. Again, what's your range of motion going all the way up? Here, okay, so when I add the weight, if it's only to here, guess what? The weight's too heavy, so we got to decrease the weight so we can get the full range of motion. So the person just kind of holds it here, make sure it doesn't fall, go straight up, ease it on the way down, let the heel drop all the way up, all the way down. Donkey calf. I don't know why it's called a donkey calf, but it's called a donkey calf. Person gets in, they're going to have their feet here, not here to push off because it puts a lot of pressure on the knees. So just be mindful of that. Have the person just put their feet right in the middle, bring themselves up. Once they're up, and their knees are almost locked but not quite, so just like this, then they could start to lower their feet down. And again, their toes should be in line with this, okay? So not too far down that the foot slips off, not too far where it's ineffective. So right about here. And you see, you could do this. That's the safer way to do it, okay? So knees stay slightly unlocked, but then that's it with the knees. They don't move. You don't want to turn this into a leg press. It's not that. Starts right here. The heels drop down. You go all the way up on your toes. And I have my hands here to make sure that my knees don't move. Okay? After a while, the person gets used to it. They can take their hands away and hold on to here. But if you can, have the hands right here so their knees don't move. You don't want to see as you come down, you start to do this. That's no good. This is an ankle exercise, okay? But having the knees locked out puts too much pressure on the knees. I don't like it. So just slightly unlock it and maintain that unlocked position. Okay, and when they're finished, then they can shimmy their feet back and bring it back down. So that's that. Okay, so seated calf raise. It's just like we're going to just call this a seated soleus raise, just because it's very similar to the one we just did with the dumbbell. There's a yellow thing right here, knob. You can bring this up. You want when the person gets their feet in here, that this is nice and snug, okay? Same thing, my toes are right in line, I come up, I pull this back, allow my heels to drop all the way. If the person wants to really get a good stretch, they can lean forward and just kind of put their hands here. You feel a great stretch in the back of the calves, all right? And so from here, go all the way up, nice and slow on the way down. It might be choppy on the way down, that just shows you that the muscle's a little uncoordinated. It's not used to doing this. So, go up. You can put the hands here, but you don't want to be pulling. It's only if like you need to get it all the way up there, that's when you can assist with your hands. But your hands just here to rest. All the way up, all the way down. See it's shaking a little bit on the way down? It's normal. All right? After a week or so of doing this, it won't do that Make sure that the person's equal in both calves, that one soleus and calf is not stronger than the other one, because if you put 50 pounds on here instead of 25, it's gonna be like 40 pounds, 10 pounds, you're gonna wind up straining this calf because it's overworking. So again, always go back to muscle balance. Don't add a bilateral exercise like this unless you make sure that both ankles are bilaterally equal in strength. So it's a great exercise to add for anybody that is, personal training, that you're just trying to get them overall strength, okay? Up and down. When you're finished, go all the way up, pull this forward, slowly on the way down, make sure it's good, visually inspect it, and then take your feet away. All right, this is something that I wanted to show you earlier. We did the standing calf raise over there where I was standing with the squat rack, but this is something that's scaled down. It's a lot easier to do. So if you want to add it for anybody, they can hold on to the table, put their feet here, basically go up on their toes, come back down. A lot of times you see like people do this without doing this, but you miss that heel drop, which is extra, which is better for the muscle to work. So they can put their hands here for balance, going up and down. You would stand behind the person, you watch their heels going up, make sure it's even, so they're not leaning on, going up on one higher than the other. So, for example, if I did this, you want to make sure that we're getting even all the way up. Not something like this and this one's lacking and this one gets up higher than my right one. So you want the left one and the right one to be even just like that, and then allow them to go back down. All right, so that's standing calf raises. All right, so we're done with the calf and the ankle. We're gonna move on to the abdominals, trunk flexors, core stabilizers. So again, scaling it back down, very easy one. It's just a posterior pelvic tilt. As a therapist or the aide, you would come over, you would slide your hand in here, and you just tell the person, press your lower back into me, or you would tell them, tuck your belly button up towards you. So they just do that. And that is the basics of just activating your abdominals. So that posterior pelvic tilt, this is your pelvis, you're posteriorly tilting it, meaning backwards, and you do that by, engaging your abdominals and your core. So they would press into you, you would feel that, and you say, okay, hold it there, and they could hold it for a few seconds. That's how you just basically start to work your abs, and then they would relax. So pull it in, 5 to 7 seconds, and then pull it out. Okay, you can take a light towel, put it underneath their back so they have some kind of tactile sensation, something that they know they're pressing into, and they kind of crush it. You can take one of our little bolster things that we have, those little rolls, and put it in there. So they kind of crush it, they hold it, and they count out loud. 1, 2, 3, 4. You want to do that so they don't hold their breath and create a Valsalva. You don't want to do that. It creates a lot of pressure in here. So they go into it for a few seconds, 5 to 7, and then relax. Okay, we usually do 30 times of that. So abdominal crunch on a half moon, and then we're going to progress to the physio ball. So again, half moon is here. I'm basically taking the half moon with my heels, and I'm activating it. I'm kind of crushing it into my hamstrings and my butt. So once you activate your hamstrings, you kind of shut off your hip flexors. And if you dig your heels down a little bit, you really shut off your hip flexors. So to kind of do, you kick it in your glutes and your hamstrings, which is a great way to shut off the hip flexors, so you can just rely on your abdominals to pick you up. Easiest way to do it is hands down here. This is the middle, harder. And if this wall was in here, arms out in front of me or above my head, that'd be the hardest. So basically this is the fulcrum, and the more resistance I have on this side of it and further away from it, is the harder it's gonna be. So when my hands are here, it's gonna be, my hands down, my forearms down. It's gonna be actually on the other side of the fulcrum, and then my arms are down here. So you basically start from here. The person's head just kind of goes for the ride, and you just tell them, just get your shoulder blades off the table and breathe out as you come up, and you're basically trying to take your chin and go in that direction. You're not, forcing your chin there, but you're just going like that. So you just come up and come back down. Come up, come back down. They're gonna feel their abs engaging. What you do first, you tell them, listen, do that posterior pelvic tilt from there, then you come up, okay? Harder is here, come up, come down. Shoulders off, shoulders back. Again, we can put our arms here behind our head. I typically don't do that because people try to crank on their neck. So from here, I compensate by not making it harder this way, but we'll take a weight, let's say a 5-pounder or anything. You put it here, they hold on, and so instead of the hands being here behind the neck and cranking the neck, They just kind of hold on to the weight here, and the same thing. Okay, it's a lot easier than to have the person hold the back of their neck and do it. So that's abs with the half moon. If you want to use the ball, the same thing. Heels dig in. So you see how I kind of do that? Activate them. Activate the hamstrings. Help shut off the hip flexors a little bit. Person can start this way. The ball wants to roll around a little bit, so I engage that much more with my transverse abdominis to hold it. So I kind of hold it in place. Same thing. Up and down. Up and down. Progress. And then progress again by using a weight. Don't give the person a 2-pounder. I mean, I just grabbed this 5-pounder. Make it worthwhile. Give them at least like a 10-pounder, or, you know, judge it by what patient you're dealing with. But you want to progress to a harder exercise if you start you're giving the person a 30-pound dumbbell. But even with a 20, 30-pound dumbbell with this, it's still hard. You're still working. So, but the rule is that the shoulder blades have to leave the table. They can't just do this. Okay, it's got to come up. Come up. Okay? That's abs. All right, so number 203, it's abdominal crunch on the bench. Heels are dug in, okay? So, same thing, come up. This is how you would do it. Give them a dumbbell if you want. They don't have to go all the way up. Their heels aren't locked in. It's just getting the shoulder blades off. So they can progress by holding the dumbbell same way right here, so it doesn't hit them in the teeth, but they're just kind of holding on to it. Or if not, if they need it to be easy, come up like that. Always breathe out on the hard part. Here. At all times, when my heels are dug in, hamstrings are activated, and all I feel is my abs. You can progress by bringing this elbow to this knee. So, opposite, then straight up. That's one. So that would be rectus / obliques, or you can write abdominals 3-way, so the person knows what you're talking about. You know, the next Aide that you go on abdominal, obliques, rectus, obliques. So it could be where you go from one side to the other, one in the middle, then side to side, however you want to do it. But, you know, make sure the shoulder blades come off like that, okay? And then you can progress to harder weight. But try to progress your patients from going on the table, try to progress them to do it on this. We have the bench here, frees up a table, and so if you guys are looking at exercises, you know, and you know, it says abs on the with a physio ball or something like that. Try to get them to use this bench. Okay. All right, lower abdominals now on the bench. Again, another great exercise to do. This thing is right here. Hold on to it. Sometimes people can't get their legs straight and get their lower abdominals. You want the feet not to go so much this way, but straight up towards the ceiling. So some people take their heels, drive up, just like that. Okay, it's not a throw your legs up. It's not that. It's up, down, up, down. If they can't do that, they cross their knees from here, try to do this. Okay, this is a step down version of it. And they can go up towards them a little bit, up towards their elbows. But again, you don't want to be kicking in the hip flexors too much. So you want to just concentrate on getting the lower back and the hips off the bench. Like that. Okay? It's great for the lower abdominals. All right, so we're going to do planks now. It's number 206, I believe. So again, if it's difficult to get up on the table, you can use the, if it's difficult to get down on the floor, use the table. If it's not, use the mat. Basically, the elbows are here, okay? The shoulders are slightly over it. They get up on their toes. As they get up on their toes, they want to do that posterior pelvic tilt where they suck in their belly button. So they don't want this, where there's an arch in the lower back, okay? You want that, where it's tucked in. Almost like a little bit of a bridge you're creating. So, elbows are tucked, abs are engaged, come on up, and you suck in that belly button. You're just basically holding it like this. If you want to make it harder, lean forward a little bit, still maintain that nice, activated abdominals. You don't want to see it start to dip and start to do this. Bring it right back in, hold it. But it's a timed exercise. A person may do this for only 10 seconds. You want to progress more and more and more. We're going to progress to the obliques. They basically put one leg underneath, this leg on top, elbow here. Make sure the person doesn't have any shoulder or elbow issues where they can't weight bear on it, okay? So from here, they would come up and tighten this up. Almost like someone's gonna punch them in the side. They call this and they engage this, and they hold it nice and tight. Okay, you can also progress with the person going up and down like this. It's just a little bit more of a dynamic movement, but they have to maintain and hold that, and don't let this happen. Up and maintain it. You would do it to the other side. This would be right obliques. If I flipped around, it'd be the left oblique. So that's planks, side planks for obliques, right or left, whatever one you want to do, or bilateral. I'm just gonna face you guys while I do this, but typically the person would be facing, the table. But they can't. You know what? I'll just face the table. So weight shifts. Let's say this person had a fracture of the left ankle or their knee or the hip, and we want to just start to get this person back weight bearing. Let's say they came in there on crutches, the leg's been off the ground, they've been in a boot, the leg really hasn't been weight bared on. We want to slowly start to reintroduce weight bearing. We have the person basically stand up. They put their, let's say the left leg is the affected leg. They put their leg here, and you just start to shift your weight onto it. Now, if this is a weight bearing 50% or whatever, the person pretty much guesses how much. But we like to go by pain level. If the person has no pain doing it, then it's probably going to be okay, unless the doctor says, hey, no more than this weight, that's it, or it might break. Fine, but the therapist will guide you guys. But pretty much, they start with the weight all on the right leg, no weight on the left leg, then they put the left foot down, and they start to shift weight over it and back. Very simple. Weight shift, you might call this 30 times, and then bring in as much weight as they can on it that is appropriate for them, and then they come back. Okay? Seems like a very, very simple exercise, but for somebody that hasn't been weight bearing on it, it's an exercise, it's work. Okay? So from here, we go into more of a weight bearing thing where we actually might have them do this and then pick up the other foot and then come back down, pick up the other foot and come back down. And that is the most basic level of weight bearing on one leg. From there, it goes to single leg stance, which they would hold themselves up, right? Typically do it here, set a timer. If they need it, they put their foot back down, 30 seconds, a minute. Once this looks pretty easy and the person's just standing there, then we progress to the foam. Where's the foam around here? All right, so we progress to this foam, where the person pretty much stands here, and you can go to, this is the lightest ball, white. There's another one that's blue, there's another one that's green, they're heavier. There's little soccer balls you could use, whatever it is that the aides can use, the therapist will let you know. There's even the physio balls, the big ones that we use to basically throw at the patient, they catch it, throw it back. So on this, you would say, all right, stand up on here, and I want you to progress just putting your left foot here, and then take this other foot off. Of course, the table will be in front of me. I'd be able to put my hands down. The half moon will be right here. If I need to put my hands down, kind of hold on, but it pretty much look like this. So in the end, it looks like this. Half moon would be here, okay? This would be here. And they put their foot right in the middle. Their hands are here if they need, but they're trying not to put their hands down. Timer would be right here for 30 seconds. And you can ask the person, listen, I want you to count how many times your other foot touches. So every time it touches, you're like losing your point. But it's better because let's say the person first starts this, and on the first day, the foot touches like 30 times. By the fourth, fifth time a person doing this, it only touches like twice. So that means they're really getting better just putting the weight on this leg for those 30 seconds. Then you can progress to the aide will be standing, let's say right here, and I'd be throwing the ball, and the patient would be catching it, throwing it back, catching it, throwing it back. Again, how many times the foot touches is something we can keep track of, okay? Taps, you say, 4 taps, 7 taps, 10 taps, so that'd be something you could do there. All right, so we're gonna do tandem stance now. So basically people with balance issues, we all know that if somebody's got true balance issues, it's good to build their, it's a vestibular issue, but if they're just like, oh, it's my balance, meanwhile it's just lack of stability due to hip strength, I wanna strengthen up the hips, but this is a good exercise to do where heel to toe. If you guys ever got pulled over for drunk driving, you probably have to do this, okay? But stand like this, you wanna do it in between a couple of tables, and they might feel like they wanna fall over, so they put their hand down here. They feel like they're gonna fall over this way, they put their hand down here. Pretty much, basically, you wanna just have your hands down to the side, okay? If they need their hands to support, they can, but hands down to the side is pretty much what you wanna do. You could switch it where left is behind right. pretty self-explanatory. They just gotta hold themselves up for a time period. So, tandem stance. All right, cone taps. Let's say we're working the right leg. So the left leg's gonna be moving outside my base of support. So come here, front, come back, tap the cone behind you, whatever the hell it is. If you put your foot back down, you gotta fix it, but there it is. Here, here. If you knock it over, just keep going. All right, front, side, back. If it was there, there. So you gotta come back behind you. Switch it to the other side, but you guys get the idea. It's basically moving the person's body weight outside of the center of gravity, which is here, or the base of support, and it's just making it harder for them to kind of have to stabilize themselves. And again, you see the ankle firing, okay? That's what you basically want. You want to create this unstable situation that if they need to, they can quickly put their foot back down, but it's like an uncontrolled kind of situation where they're moving their body weight around, they're kind of doing this, and it's a lot on this hip and on this lower extremity to kind of keep themselves nice and stable. But you would do this maybe in a squat rack where the bars are on either side of them to kind of hold on if they need to, and the therapist will pick which patients are appropriate for this. Rocket board toss, basically what you want to do is have the person get on it like this, and they hinge their feet back. Best thing to do is the bone on the outside of the ankle, that's why I have these up, is to be in between. There's two sets of screws right here in between this. So that's where you want to be. The person's going to say, wait, I'm too far forward, but that's the way they're supposed to be. Forward center, and they got to work to get back on their heels, all right? If they feel like they need to, they go back sometimes, they're like, whoa, and then they can put their foot down. Sometimes people will do this, they'll start doing all this, they're going to fall off. So just tell them, look, don't wave your arms, take a step back, make sure there's nothing behind them. So they're going to stand here, all right? And like I said, the key is to get the front off. And then there's going to be a therapist in front of them or an aide. You can throw the ball, but just make sure it's not here or lower because the person's going to lean forward to catch it. And you don't want to create this. You want to create this getting back on their heels. So Dan's going to throw the ball to like there. So I'm getting off, all right? If I need to step back, I step back, all right? But eventually the person does this, and the best thing to do is to say, do not worry about your legs, just worry about the ball. And this may take me several times until I figure out, okay, I'm going to stay back, get the front of this thing off the floor, and the higher he throws it, the more challenging it is, but that's what you want, okay? If the person jumps off, 10 times, it's better than you throwing it down here and they're not getting anything out of it. So now you can see after a while, it's easy to keep this up, okay? It took me a few tosses before I had to get back off. And the person sometimes starts to move their feet back, but you gotta constantly watch and say, no, stop, move your feet back forward again. Especially if you start to see the person become successful in it, it might be that they're cheating. So you throw it up, okay? And they have to step back. So it's not that easy to do when you first start, but pretty much when you check the person's center of gravity, or where they're, center of which way they're leaning, before they start, they might be like this. After they are done with it, they're back on their heels like this. So it's a great exercise to get them back. It works out your hamstrings, your dorsiflexors, your mid-trap rhomboids. It's a great way to get back. Now we're gonna go a little harder. We turn it this way. And let's say it's an ACL patient, ankle patient, hip, anything that you want to create, like we just did the cone taps. This thing it's going to wobble one side or the other. There's a blue dot right in the center here. Put their foot right in the middle. The knee is slightly bent. And then the other foot, if they need, they tap down this way. So Danny starts to throw it. And what I want to do is maintain this position. And then what he could do is start to mess around with my base of support, right? So this way, I don't know where he's going to throw it. Up or down, left or right, but right now my ankle's firing, my quad's on fire, everything's working because he's working me on different angles, different positions, and the whole time I'm holding this position, all right? So it's a great exercise to do for anybody that has any kind of ankle, and again, it's an exercise you would do in conjunction with where there are ortherics. So if the person's just doing like, dorsiflexion with the T-band or some active range of motion stuff, you wouldn't be doing this. This would be somebody who's doing, single left leg press or lunges. It's a higher level proprioceptive exercise to do. All right, so these are the different surfaces somebody could work on. You want to always go from, we put G as ground, okay? So they're just on the ground. So it could be single leg stance on ground for timed. It could be single leg stance on the ground tossed. You could also do single leg stance ground toss with some perturbation. That means the therapist will literally be behind them, just kind of giving them taps to kind of just throw them off. You wouldn't be like throwing the person because then they just land up on the floor, but a little bit of taps, like somebody behind me, I wouldn't know where it's coming from. Either tap me forward, pull me back, shift me to one side, shift me to the other side while I'm catching the ball. They can push on your hips. So those are the three things. First level is what you're standing on. Second is whether you're doing it with a toss. Then the third, making it harder, is with perturbation. So you can write all that. Then the next level, you want to do that same level of, okay, standing, then tossing with perturbation. You move on to the foam. So it's F for foam. Same deal. From there, you move on to rocket board. You know, if it's a single leg. The same thing we just did before where we were doing the toss. Let's say he was just tossing it back and forth and somebody's behind me now, just kind of, you know, tapping me to one side. If it's an athlete, you do little head taps, put your hands in front of their eyes, just you can get creative with it, but you're making them be much more, you're concentrating much more on the stimulus of the ball, plus with all these other distractions going on. From there, you can go to the trampoline. Trampoline might be even with the foam, maybe not as much as the rocket board, but see how your patient does. Same thing. You're throwing the ball back, they're catching it, somebody's standing behind them. So the progression is what they're standing on, then the toss with a perturbation, okay? Then you go on to your Bosu ball. They're standing right in the middle on it, okay? This is not that easy. Catching the ball, going back and forth. You can see the ankle fires like crazy when you're on it. It's a great ankle exercise to do. Okay, tapping the ball, catching the ball, and then somebody behind them, tapping and giving them a little perturbations. Again, hips on fire, knee works, ankle works, everything's great. Final one is your cortex, where you see this, not a lot of friction going on at all. A little bit of tap just keeps it going. We get a little sign here that says, don't let anybody stand on this thing without therapist being with them. They always need to hold on. So they get on this thing, put their foot right in the middle, okay? And they can basically have their hands just holding on, and you would tell them close your eyes. Then an aide would get down on the floor and basically move the disc around. So the person doesn't know which way it's going to go, and you can be in a little bit of a squat as they're doing it, forward, back. Doesn't fly around a lot, but that little bit, you know, we really don't do any kind of toss with this because it's just so unstable. But this is something the person just stands on, and you just do a lot of perturbations from here. And when you're doing your perturbations, which is your taps, don't be, don't be doing the same thing. Don't be rhythmical. Like, oh, this way, this way, this way, this way. You know, do this, 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 this. So the person doesn't know where it's coming from. That's a lot better rehab for the person. So you can do this with 2 feet. The person is just trying to, you can tell it's just going all over the place. They're really holding on. All right. But once they're on it and they feel like, okay, I'm on it, then you can start, all right, close your eyes and we'll start giving you different perturbations. And it's a great thing for the proprioceptor. But typically this is done with 1 foot.